Good evening, ladies and gentlemen. Hello, dear friends. My name is Vasily Rakhovi. I am the hand transplant patient and the founder of the Voice of VCR Patients from Innsbruck, Austria. Welcome to the interview. This time, our guests are Mrs. Marcia Bale, the first bilateral hand transplant recipient in the Netherlands, and Professor Steven Hovius, leader of the hand transplant program at Red Boat University Medical Center in Nijmegen, and a former head of plastic and hand surgery at Erasmus University Medical Center in Rotterdam. Good evening, dear friends. Nice to see you.
Nice
Good
to see you
evening.
too. Good evening.
If you don't mind, I would like to start our conversation with a philosophical question. Miss Bale, your life is like three lives in one, with the hands, without hands, and with the new hands. May I ask you, have you ever asked yourself why it happened exactly to you? Do you see yourself as a random victim of tragic circumstances that might happen to anyone, or it has a deeper meaning and had to become an integral part of your life journey for some reason?
Okay, well, I don't believe in a deeper meaning.
Hmm.
But of course, in the beginning, I questioned myself, what could have caused this?
Hmm.
I became real sick in a very short time. So I asked myself, yeah, did I eat something wrong, or was I bitten by an insect, something like that? And also the doctors tried to find out whether I had infections or maybe little cuts in my skin what could have infected. Um, but yeah, I didn't know anything, and my doctors couldn't find anything. Only thing that they find was that I had a ear infection several months before, a few months before, and yeah, that didn't cured properly. So maybe that was the reason. Um, but yeah, they doubted about whether that was the real reason, but we never found it. But no, I don't believe in a deeper meaning of that.
Thank you, Mrs. Bale. Professor Hovius, what is your opinion about such life situations? What way of thinking seems correct to you in that case?
Yeah, I believe in bad luck, if you see what I
Mm-hmm.
mean. And I don't have a religious feeling about it or another philosophical feeling about it.
Mm-hmm.
And I just wanted to help Marcia because she had a problem, and I thought she was a very good candidate. That is basically what was my first thinking when I met her, when she had the lower limb wound of the amputation of both legs, because she's a quadruple amputee
Yeah.
from the start. So two lower limbs below knee and two hands. So
Yeah.
my whole philosophy is more, how can I help?
Yeah. Understand. Thank you. Mrs. Bale, every tragedy has its own beginning. Could you tell more about the disease that had such catastrophic consequences for you? How did it unfold?
Yeah, well, at first, I wasn't feeling very well. I thought
Mhm.
I had the flu. Only, yes, I told already before, I was sick, became sicker in a real short time. So we had to call the doctor, and the
Mhm.
doctor sent us to the hospital. And yeah, I had a very low blood pressure, and they saw already that my hands were turning blue.
Mhm.
So yeah, they had to put me on life support. And after more than 2 weeks, I came out of the coma, and then I found out that yeah, my feet and my hands were already necrotic.
Mhm.
And yeah, because I was still very sick, they had to amputate my legs under the knee um, very quick. So they left it open as an open wound
Mhm.
because they couldn't have a real long surgery. And yeah, then later they closed it with the skin of my upper leg. And then later again, they had to amputate my left hand completely and the fingers of my right hand and half of the thumb.
Mm-hmm.
Yeah.
Yeah.
So yeah, at first they didn't even know whether I would survive this. But yeah, when they removed or amputated my limbs, it got better. And well, then at a certain time, of course, I thought, yeah, what is my future life? What's my future
Yeah.
life gonna be? But yeah, after 7 weeks in the hospital, I went to a rehabilitation center, and there, yeah, they learned me to how to deal with my disability that I have right now. Yeah.
Yeah. Yeah. Professor Hovius, could you tell our viewers, please, about the hand transplant program in Nijmegen? And of course, it would be very interesting to know how did you meet Mrs. Bale, and why did you think she was an appropriate candidate for the surgery?
Yeah, I think there are different parts of the in your question.
Yeah.
The first part is how did I meet her? And she had a problem with her lower limb, like I said, and
Mm-hmm.
so we first tried to cure that the wound on the lower limb, so she could wear prosthesis. And I think in a quadrupled amputee, it's very important to have first your lower limbs sort of corrected, in this case with prosthesis. Mostly it is, by the way, prosthesis,
Mm-hmm.
and then move on to the hands. Why?
Mm-hmm.
Because you have to be stable, can do rehabilitation and so on, do not have to worry about your lower limbs and so on. So in every quadruple amputee, I would always advise first to do the lower limbs to have a good mobility. For the second part will be the hands. That's one. Two
Mm-hmm.
is, and so why did she come to us? Because of the wound in her lower limb, and she was already, I think, 1 year after when you
Mm-hmm.
came, when I
Yeah,
saw you
1 year.
first, one
Yeah,
year
was
after.
1 year.
And then I sort of said, "Have you ever heard of hand transplant?" She didn't, and she said, "Well, look at internet and come back if you feel like it." Because I felt from the beginning, I think everybody has that in your first few seconds you think somebody is suitable, yes or no, and then you start to look if that's true or not, huh?
Yeah.
And it's a sort of beginning feeling you have with every contact. At least I have.
Mm-hmm.
And um, and I thought she was a very good candidate. So I didn't push her at all. I said, look at it, and if you want to be very clear for hand transplant programs, I'm very critical. I would not do one hand. She even asked me to do one hand, but I said no because it's your worst hand, and then you will not be happy because your worst hand will not become a good hand. The good hand will be the best hand now, because then I can improve that best hand better. And I can go into a little bit more detail if you like, but that is what was the basic way of thinking. So
Mm-hmm.
to my mind, don't do the worst hand, do even better, do the best hand from the two damaged hands, if you want to take one. Yeah, but it's a very different feeling than patients have, because they of course want the worst hand to be done. Yeah.
Yeah.
So that's a bit of an explanation about two hands, yes or no. And
Mm-hmm.
the second, no, the first most important part
Yeah.
is your psychological well-being. And
Mm-hmm.
Marcia was a very good example of psychological well-being. A stable person who is faithful to medication and taking it, and to rehabilitation, who wanted to become better, who had a motivation, and who had a good surrounding with family and with friends and nearby, etc., to help her cope with the whole problem. And I think she did very well with that. So what else what I didn't answer yet from your questions?
Yes,
Oh, the
about
program.
the hand
The
transplant program.
program,
Yeah.
yes.
Mm-hmm.
Well, then we can, if you have that basis, then you
Mm-hmm.
are motivated to start, because it wasn't there in Holland. She was the first one, and until now, to my knowledge, the last.
Mhm.
So we started in Rotterdam because she lives in Rotterdam, and she came in the last part of my time being in Rotterdam.
Mhm.
And we first, of course, did the wounds. Then she said, yes, I would like to explore it better. Then I started to, and that's on my own. That wasn't a program yet, but that's purely first psychological profile by a psychologist, and two was to confront her with everything we knew about hand transplants. And
Mhm.
and then we started to motivate the team that was still in Rotterdam. Now I'm talking,
Mhm.
and we started exercising in the anatomical lab. Yeah.
Mhm.
So it is not like you have a transplant program like that. It's more
Mhm.
like building it slowly from nothing to coming to a new thing. And of course, we are huge trauma center, and with replants and microsurgery and that whole stuff. So that wasn't the point.
Mhm.
The point was more the whole logistics and everything around it. So then you have, to my mind, three chapters. First, it is the patient.
Mhm.
Then it is after the transplant has been done, so patient and operation. Then post-operation, meaning
Mhm.
medication and rehab. Yeah. And then the donor is the other chapter,
Yeah.
and the donor with everything around it. And then there's the immunologic part. Huh?
Yeah.
And if you go, and I always, if you have lectures, I'll always do it in those kind of, in that way. Yeah.
Mhm.
The patient, of course, needs to be, how do you say that, to my mind, confronted with all the problems you can have, like you were saying, after COVID. And
Mhm.
so that means rejection, that means long-term complications, that means problems with medication, complication with medication, your immunosuppression, and the whole stuff. So we organized a symposium in Nijmegen because
Mhm.
at my farewell from Rotterdam, the Professor Ulrich asked me to come to Nijmegen and to do the program there. And
Mhm.
I said yes because I wanted to go on, yeah,
Mhm.
and give her the chance. And it was not possible anymore in the old apartment where I was, yeah, because
Mhm.
I was out.
Mhm.
And so we went to Nijmegen, and there we started again on making a roll of protocols, about 30 protocols for every little thing was a protocol. Yeah, it
Mhm.
had to be from the university out. The board of directors were very positive and helped us also. The transplant society, we had to talk there. We had to go to all the ICUs for the donor, um, all the big ICUs in Holland. And those were, I did about the big ones, I mean, who have very often people who are dying and who have a codicil, etc. What I'm trying to say is that it is a huge logistics around it. It's
Yeah.
something which took me 1 year in Rotterdam and another 2 years in Nijmegen. To give you an idea that I was sometimes hopeless. Not always, of course, but sometimes I was. For instance, when the Dutch ministry said no, and
Mhm.
because insurance said yes, which is very
Mhm.
important. So money is an important
Yeah.
thing here because it's expensive. Um, Also from the medication, lifelong, they also said
Mhm.
yes. So that was not a problem. The board of directors was, and the whole hospital worked with us. The teams were very nice. The PR, the whole shebang, everybody who around it. But the Ministry of Health said no. Why? Because she didn't want. They didn't. They said you'd have a codicil, a donor codicil, and
Mhm.
the donor codicil is important because if you haven't filled in the donor codicil, then you're not allowed to ask anything at all. Yeah,
Mhm.
and they changed that for us in the sense that we were not allowed to do it anyway, because if not everything was said okay, then we were allowed to ask it in the end. But in the beginning, they said, no, we don't want it. But then said, how did the heart transplant begin? How did the kidney transplant begin, etc.? They also have first time with risks, etc. Yes, but that's another thing. They're on the donor codicil, you're not. And you're not going to do it so often. So, yeah, so they said basically no. So I was a bit down, and I asked the board of directors what we should do, and they supported us to get in a second opinion of a professor of of healthcare and of the legal stuff, yeah, a lawyer, but in specifics of healthcare, yeah. And he's so well. There are some. It is with the current legislation, you may be able to do it. So we were a little bit supported about that. And then the Transplant Society called me and said, we have a new lawyer and they think it's possible. So you can go ahead. But you have to have a donor codicil which says yes to everything. If a donor codicil says no to eyes, for instance, then I mean, of course, I mean the cornea, yeah. And then you're not allowed to ask for hands. So that meant from the 15 possible donors we had in that year, we only 3 were eligible. Oh, sorry, eight were eligible, and only 3 were had a donor codicil who were okay, and 2 were not how do you say that, compliant for Marche, meaning the HLA, the antibodies, yeah.
Yeah.
And only 1 was compliant for her with immunosuppression. So that was a long story for the law, if you like, and for the ministry. And then the second big problem was her immunology, and we had to cope with that and try to figure out what was possible, yes or no. That was also why from the 3 eligible, 2 were no-go. Which meant that you are ready, that you come to the hospital, that everybody thinks it's going to happen, and then you're really nearly there, and then and it stops because the immunology was not compliant enough. You never get it completely compliant, because we're not identical. But if you have a match which is like that, instead of that is complete, that is nothing. And if you have it somewhere here, then you have more chances of not getting rejections. Yeah. So that is the part from the donor and from the acceptor. The acceptor was, we had of course the team who goes to the person who is deceased and gives the arms. Yeah. And those are 2 teams on both arms, because we were in front of everybody, because we needed we didn't like any bloodless fields, so we wanted to have blood in the arms as long as possible. So the time without blood, it was as short as possible between transport and recirculation. Yeah. Am I understandable for you?
Yes, of course.
Okay. All
Yes.
right. And then so we trained hard for that. I think we've trained about 30 times in the anatomical lab with teams, complete teams, trying to work it out so that we were like a military operation. Yeah. So that is from the recipient. And then you have after you have trained for that and done that, the HLA is all right, then you can go ahead. And there were 2 teams on site with the patient Marche, and there were 2 teams outside getting the arms from the same patient, by the way, and having, so we had 4 places, 4 teams, and they merged to 2 teams when we prepared the donor arms and came back to there. And well, in total, it took us 24 hours, and we had 6 hours extra because one of the vessels was clotted because of ICU, they have punctures at the arteries, and it stopped there. So we needed to do a new graft, a longer graft. That's why it took longer. But normally would say about 18 hours, but now it was 24. And then came, of course, the medication. This a kidney transplant doctor helped her for the medication, and then the rehab, did a huge amount of rehab in terms of physiotherapy, a couple of times a day, like in the beginning 5 times a day, I think, Martje, or something like that.
Yeah, yeah, it
And
was
the
5 times.
first 2 months we did very intensive, and so intensive that Martje said, "Could you stop, please?" No, that was a joke. But no, anyway, and I think Martje should say something about what it did to her emotionally, and maybe you should tell me about your daughter, Robin. And but this was the whole organization, and so in total, it's a whole transplant program. But in reality, especially the first time, there's no room for error. You're not allowed to fail. If you have done 20 or 30 or whatever, then you might fail one. And she's been a wonderful patient. No infections after 4 years, I think. It's now 7 years. She had one quite severe lung infection, and it took a couple of months, but actually further hardly any infections, and one rejection after 2 weeks, which I thought I died on the spot when I heard that, but we started very quickly, and the rejection was gone in quickly, because it was not a heavy rejection. It was, but still. And why was that? Because she had a lot of problems with her intestines, and was vomiting a lot and things like that in the beginning, and so the uptake was not good. Yeah, I think that's the reason why she didn't work so well in that particular time frame. Yeah, further was quickly restored, and she's doing well 7 years out now. Yeah.
Yeah. Yeah, thank you, Mrs. Bale. There is a common stereotype in the society that living with amputation is especially difficult when you are young. Young people are more concerned about their appearance than the adults. Growing older, the practical aspects of life, first of all, I mean health conditions, become more important than the appearance. At the time of the surgery, you were an adult woman. May I ask you about your reasons for undergoing the hand transplantation, please?
Yeah, well, the main reason why I wanted the hand transplantation was for my independency. For me, or I think for everybody, it's always difficult to ask other people to help you to be
Yeah.
independent. So yeah, for me, it was to have independency so I could be able to do more things by myself. That was very important for me. So like walking up the stairs, so I could hold on. I was more confident driving my car, or yeah, do everything in the bathroom, dress myself, everything like that. And now I'm also able to work on the computer, which I couldn't do that before. So yeah, I'm very happy about that. I wasn't busy with how I looked, or how I would look after the hand transplantation, but well, I'm very happy with the way it looks right now, and yeah, especially how they function.
So to say, independence, improving of quality of life, these were your main reasons for the surgery.
Exactly. Yeah.
Yeah.
Uh,
And if you dissect that, she had to tell us the 6 most important things to achieve, and that was, of course, a choice, but it's not comprehensive. But but I think that's called the COPM performance rating, and she chose to walk the stairs because with two limbs and two hands, it's more difficult, of course. Second was to do mascara and things like that, to make makeup.
Uh-huh.
A third thing was to be able to eat outside in a restaurant.
Mm-hmm.
Fourth thing was, I'm not saying the same priority. I'm just saying the points. Yeah.
Mm-hmm.
The fourth thing was to be able to do something with a pinch, to put in something in like in a slot, a card or things like that.
Mm-hmm.
Am I 5 or 6? I don't know anymore.
Oh,
Anyway,
fine.
five. Then it was to, yeah, of course, to dress herself and to
Yeah.
be independent in that way, and to be able to do household cooking,
Yeah.
etc. And her job. She has a job doing computer. She told that the computer was
Mm-hmm.
one of them. And driving a car was also possible before that with special things, but was much
No, I
easier.
didn't have
Oh,
I
yeah.
didn't have special things.
Okay.
Only it makes me more secure when I can
Yeah.
yeah,
Yeah.
hold the steering wheel.
And there was one other thing, walking with the dog. With
Uh-huh.
Yeah,
with the
Uh-huh.
those were the points you chose. I don't know. But
true.
yeah.
Miss Bell, it is very difficult to drive a car after the hand transplantation. Much more difficult when it was before the incident, before the
No, no,
disease.
it was, yeah, I was able to drive the car already,
Mm-hmm.
also without the hand transplantation.
Mm-hmm.
And yeah, I was driving the car like everybody does, so there wasn't anything in the car different.
Mm-hmm.
Only, yeah, now I have the hand transplantation done, I can um how do you say, get a grip on the steering wheel better. So when
Mm-hmm.
I want to close my window, for instance, as well as steering, I can do both. And before, that was difficult. That was very difficult. So when my or other buttons, the heating or every button that you use in the car,
Yeah.
that was difficult to do when I was driving. Yeah.
Mrs. Bale, Professor Hovius, after being a few months on the waiting list, I suddenly received a phone call from the clinic that there was an appropriate hand donor for me. I don't know why, but I was so scared after that call that I couldn't even walk on my own. I completely fell apart. I couldn't believe that the day I was waiting for so long finally came. 10 minutes later, I received another call from the clinic saying that the surgery was cancelled for some reason. Mrs. Bale, I have heard you went through the same experience twice. Could you please explain what way of thinking would be helpful in that kind of situation? And maybe you could also tell about your emotional state after receiving those calls. What helped you to calm down, to relax, and look ahead?
Okay, well, yeah, I was, of course, very excited when I received the call.
Mm-hmm.
But yeah, during the process, um, yeah, there was, I knew there was also always possible, though, sorry, that it was always possible. I kept in my mind it was always possible that they canceled it again.
Mm-hmm.
So
Mm-hmm.
when I first got the call, I always kept calm until I should receive the call whether, yeah, I had to come to the hospital. So yeah, I received the call twice, and
Mm-hmm.
twice it wasn't going on. And the third time I actually went to the hospital. And well, actually, I couldn't believe it still when I was already in the hospital.
Mm-hmm.
Only when, yeah, when the surgery was going on, I had to believe it. But uh, yeah, I always kept in my mind, it's always a possibility they cancel it more than I
Mm-hmm.
thought, oh, it's going to happen right now. Yeah. at
So
that
to say,
time.
you were prepared for this possibility
Yeah,
first.
I was
Yeah.
prepared. Yeah, I
Hmm.
always was prepared because
Hmm.
I knew I had well, Professor Hovius told you already. I don't
Hmm.
know the real words, but I had more reason that it would be rejected with me.
Hmm.
So yeah, I kept that in mind always. Okay, well, maybe that is my personality that
Hmm.
yeah, that I did keep calm and yeah, I was always surrounded with other people. So yes, of course, when I got the call, I called everybody who wanted to know. And of
Hmm.
course, my husband, because one time my husband was at work and I couldn't reach him. So, and I had a little daughter, so I had to take care of her. So,
Hmm.
in an instant, I was busy. What do I have to arrange for her, and what do I have to arrange to come to the hospital? Do I have everything that I need? More like that, practical stuff.
Hmm.
So, yeah, it always was a disappointment, but I
Yeah.
think that for me, it was more important that they found a person that yeah that was a good match with me. So we did have yeah more security about the success of the operation.
Hmm. Professor Hoyos, how do you think should the patient experience be taken into account in the development of psychological preparedness protocols for the hand transplant patients? Would the field benefit from having this experience?
Yeah, I think so. Yes, absolutely. And let's be very clear also, and Maartje Bijl took that quite well. I said, I want to show you every complication you might can get.
Hmm.
And if you say that's too much for me and I don't want it now anymore, then it's a good decision that we didn't do it. Yeah.
Hmm.
Because and that made her more, yeah, resilient to
Hmm.
not be so anxious about everything. Um, and she knew that we would do everything for her as what is in our possibility, but she also knew that it could fail, and not only in the beginning because the failure in the beginning is slow, but later on. And I think my message would be to every new one, really convince yourself that you know what can happen and deal with it. Because if you do not deal with it, you get a very set of mind. Yeah.
Yeah.
Yeah. And I think, of course, she was afraid when she saw the pictures and things like that. But I think the reason why she's calm is because of her personality, one, two, three, four, five, but also because of the fact that we have told her everything we knew
Hmm.
in a very confronting way. Yeah, this can happen, that can happen, etc. We had a special symposium with a patient from Austria, by the way, and who had it already. You have it now 20 years, but he had it already something also at that time, 20 years. That was like a decade ago, and so she could ask him anything. He was there in Nijmegen. And we asked the speakers from Austria, speakers from Lyon, who had experience, to tell everything. And they told
Hmm.
us everything. And she was there at that meeting. It was a symposium for more people, for everybody who wanted to be there from the hospital, etc. But also for her, especially also for Maartje Bijl. And
Hmm.
yeah, to my mind, but maybe Maartje, you should say something right now. To my mind, that helped to I just say that to be strong enough for it. Or is that
Hmm.
not true?
Yeah, that I was yeah that I was well informed. That
Yeah.
helped throughout the process. That was very very good support.
Mrs. Bale, may I ask you a bit sensitive question, please? Did you care about the appearance of your new hands before the surgery? I mean, whether they would much to your body or not about the skin color and so on. And in your opinion, do the hand transplant patients need any psychological support before and after the surgery? It would be very interesting to know your opinion on this issue, please.
Well, about the appearance, I wanted the hand transplantation more for the function and independency than for the appearance. I felt never ashamed about the way I looked, but I was very aware of my dysfunction, and that could make me more insecure than how it looked. But yeah, Professor Hovius always said that they would look for a donor whose hands would be suitable for me. So yeah, that convinced me. And of course, the psychological support I think is very important, but I think it is different for everybody. When I was sick in the hospital, they advised me to talk with a psychologist. And I just woke up, and so the psychologist come to me, and but two young women, and everything they could say to me is how sorry they were for my situation. So, well, that didn't really work for me. Um, my support in the process in the hand transplantation was, as already Professor Hovius told me, was the honesty of him, how the process would be. And yeah, they were very honest about every aspect, everything that I could expect, and everything about the surgery, the rehabilitation, and the medicine, the immunosuppression. So yeah, I was really prepared for everything, and that helped me during the process, as yeah, Professor Hovius already said.
Yeah.
Well, I also could speak with the nurses and the therapists very good. That helped me after the surgery. So yeah, for me, it's easy for me to speak with the people around me. That's my psychological support. And yes, of course, my family, my husband, my parents, and my siblings, and my friends, they stood by me, and they stood always after my decision. And yeah, they still support me.
Mhm. So to say, family support, support of your friends, your daughter, that was all parts of the success, so to say.
Exactly. Yeah,
Mhm.
exactly. For me, that was for me, yeah, the main, how do you say, the support? Yeah, more than a psychologist for me. But it's different
Yeah.
for everybody. But I
Mhm.
think you need people around you
Mhm.
to speak about it, but also to speak about other things during the process. So not only hospital things, medicine things, also yeah, when your sister come to talk, ask her about her life and what's going on in her life, not everything about me. For me, that's yeah, that's working.
Mhm. Professor Hovis, you have already told a lot about the surgery, but could you also explain our viewers, please, why do surgeons have only a few hours for the hand transplantation? As I understand, there is organ preservation time limit. How
Yeah.
long is it? Could you tell us more about
Well,
it?
you have to know that in replantation surgery, when an arm is cut off or a hand is cut off or fingers are cut off, that's the different thing. Here it's the forearm at the forearm level. It's is a transplant. In the replant surgery, how more muscle there is in the arm, how more problems you have if you take too long. And
Mm-hmm.
what is too long? Too
Yeah.
long is 6 hours or more. And because then the damage of the soft tissues, not the skin, not the subcu, not the fat, but the muscles and the nerve. The nerve is it comes next. Then comes and the skin comes nearly last, and the bone is at the last because the bone is not so bad in that sense. Yeah, and you can take a long time off for the bone, but not for the skin, and not especially not for the vessels and for the muscles. Nerves are then, and then the skin. So there's a sort of time frame for everything. And if you are going over 6 hours, then you have more chances of problems. That's why we cool the donor arm, and we have cool packs underneath the cloths of at the table, and put the arm on that, so that you have more time. And in her case, the right arm was done in 6 hours, but the left arm had, because it was a very bad arm, we had decision problems during operation, and we made decisions took us a little bit longer to make final decisions, because we even thought of doing it at the elbow for her. But we decided not to do that and do tendon transfers, meaning that tendons were moved to other functions for those muscles which were still all right, and the hand tendons were not good. But and she can show you easily the difference between one hand and the other hand. So that's the explanation. Yeah.
Yeah, understand. Thank you. Professor Hoyos, Mrs. Bale, I think you agree with me that sensitivity in our hands is one of the most valuable, important properties of the human hands. Feeling of the sun on our hands, chill of the cold water on the skin are amazing sensations that millions of people take for granted. Mrs. Bale, may I ask you to tell about the sensitivity of your hands? Can it be compared with the sensitivity of your previous hands, if I may say so? Please.
Well, I cannot compare the sensitivity in my hands with the sensitivity as I had in my hands before. I can feel hot and cold, but I always have to look at my hands when I do something, to be sure, actually, to be sure that what I want to do is going all right. So yeah, it's much less sensibility, but yeah, I can feel cold and hot.
Professor Hoyos, as we have just learned that Mrs. Bell is the only one hand transplant recipient in the Netherlands. Therefore, it would be very interesting to learn how her follow-up works. In your opinion, are home physicians able to provide the follow-up for the hand transplant recipients, or they should work in collaboration with the clinical transplant team in order to provide the follow-up for the patients?
We had already people around the transplant program in Rotterdam who were disappointed we didn't do it there. And that was, for instance, also a transplantation doctor. And after Nijmegen had said, well, you don't have to come here all the time. The medication doctor can also be in Rotterdam, and it's very close for you. And so it's easy to go to. And I had very good contact with him too. And he's a marvelous person and takes care of her. The rehab center is also in Rotterdam. So if she wants to go there, she can easily go there. But for the plastic team, then she would go to the Nijmegen, because they are the ones who did it and they're the ones who know exactly what happened. I think you should have, at least for the medication, you should have a transplantation doctor having the knowledge, and not a house doctor or home physician, because you can have that for easily for not so heavy stuff. But as soon as the medication changes, you need a transplantation doctor. And every big university in Holland has a transplantation doctor. So that's not a big deal, but you need the experience of those people. For the hand therapy and for the rehab, well, as long as you know what to do, then you can do that anywhere, with experienced people, of course. But it's nicer to have people who know marching. And for the home physician, all the small things she might have or somebody might have, of course, they can do that very well, but they have to take into account, like for instance, you had the COVID,
Yeah.
and then a home physician should be very well aware that you have immunosuppression, that you are, how do you say that, a more special patient than any other COVID patient. Yeah, because you have to take care of the fact that your immunosuppression is not as well as in the normal people. And so to answer your question in general, for the simple stuff, well, the one who knows her and a home physician as well. For the medication changement and medication controls, and the levels, etc., etc., the transplantation doctor is very important. And
Yep.
maybe one thing is also important. I don't know how about you, but March, it was very difficult to puncture, for venous drips and for injections and all that stuff to get blood. And so she still has a device where you can get blood from in her chest. Yeah,
Mhm.
and it's there already now 7 years, March.
Yeah,
Yeah, it
from
hasn't
the
changed.
beginning. Yeah,
Yeah, and there's no problems there, huh?
no problems.
No.
Mhm.
So that's quite important for her, because if you take blood, it's not as painful and troublesome as, and you don't want injections in the arms, not in the beginning at least. And now it wouldn't be a big problem. But well, those things are important. But of course, there's something for Marche, which is important, very important, that she doesn't have that pain, that constant nagging at her arms and things like that, trying to get blood. Those are little things, but in the end, very important.
Mrs. Bale, Professor Hovius, my last question is to both of you. How do you think? Why is there only one hand transplant recipient in your country? What does it depend on? Are people with amputation afraid of side effects of immunosuppression therapy? Does it depend on insurance? Do people with amputations come to terms with the loss of their hands? Or are there other reasons for it? What is your opinion on this matter, please?
Yeah, I don't really know, because yeah, I don't know that people, but yeah, it's quite a process, and you have to be sure that you really want this. You have to accept the risk of the operation, possibility of rejections, and the side effects of the immunosuppression. You already say that. So yeah, maybe yeah, other people think that is too much. Um, to take the risk.
Mhm.
But yeah, I cannot, I don't know. For me,
Mhm.
I can tell you that if I didn't meet Professor Hovius for another operation, I wouldn't even thought that it was a possibility. I didn't
Mhm.
think of that. So yeah, that's why I think that your initiative for this international VCA patient organization is such a good idea.
Thank
Yeah,
you.
for people to yeah, for people to look at the possibilities, and maybe yeah, have experiences from people who have gone through the operation can yeah, can be a help of making that decision.
Professor Hovius, what is your point of view on this question? And could you also tell about the development prospects of the field of VCA in the Netherlands, please?
It's not easy. And it depends very much on the insurance company. It depends
Mhm.
very much on your surroundings. Where do you work? Do you have experience with replants, etc., and big traumas like that, and microsurgery? That's from the organizational point of view. From the people point of view, luckily enough, factories and all that stuff are much more safe than in the earlier days. Of when in a huge trauma center where I worked for a very long time, we had 450 severe cases per year, and it dropped in 20 years' time to like 150. So and that is, I'm not saying that is all because of safety in the factories, but I'm
Mm-hmm.
saying it helped a lot and people are informed, but still it happens, of course, but not
Mm-hmm.
as much as in the earlier days. That's specific for trauma. Most of our cases are septic patients. And of course, there are trauma cases, but those are mostly one hand. So rare to have two hands at trauma. That's more for the explosive people, who are working
Yeah.
with explosive and things like that, like policemen and so on, or special
Yeah.
trained people, military. Um, that's why in the US they have so many people, for
Mm-hmm.
instance. And but I've encountered many patients who were sick and have lost more limbs than only one hand. Yeah, and
Mm-hmm.
uh, and I'm very strict about people who have one hand only because I've had quite a few patients coming to me with one hand, and so yeah. And we didn't make a lot of noise about it. We did it in the medical
Yeah.
field, yes, but not we were Marcia, once we were on television with Marcia to get the donor to make it more feasible that we needed a donor. And
Mm-hmm.
one
Before
time
the surgery. Yep.
before the surgery, and one time 1 year after surgery,
Mm-hmm.
just to show that it was okay and it was successful, etc. And from my point of view, I tried to protect her, and so she will not be like a special animal at the zoo. And
Yeah.
and but that's my feeling, and I know that there are other people who think differently, but too bad. Yeah.
Mm-hmm. But do you think will this field develop in the Netherlands? Maybe other type of external organ transplantation, such as face transplant, abdominal wall.
If you see how the ministry reacted to me, and with a very simple question, with a quite clear case, and how they reacted, well, it's not so easy, think, especially not for face transplant. We have people. I asked Dietmar Ulrich, you know
Yeah.
him, to be trained for face, and
Mm-hmm.
and then I sent him. He was a staff member at our department, or in earlier times. Later, he became professor in Nijmegen,
Mm-hmm.
and he was sent to Paris to learn that. But actually, it never really stayed on. And the hand transplant, well, like I said, the real cases, which I thought were valuable cases, only about three or something like that. But and more often, no.
Mm-hmm.
Um, and people from outside, like Ukraine war casualties, that's a difficult thing in payment. They get 1 year, and you cannot do a patient with 1 year. I mean,
Yeah.
you should have that happened in the Lyon case after they didn't have money enough to get medication later on. The first hand transplant.
You mean Clint Helm?
Yeah,
Mm-hmm.
the first hand transplant for the was stopped because of he couldn't get money for the medication from the insurance because he was a foreigner,
Yeah. He
and
was from New Zealand.
foreign for France he was a foreigner, so he didn't
Yeah.
have a
From
French.
New Zealand, he was.
Yeah,
New
yeah, he
Zealand.
didn't have a French
Yeah. Citizenship.
citizenship,
Yeah.
so he didn't get insurance from France.
Mm-hmm.
In Holland, as one, if insurance says yes, then it's everything is yes. But we experienced also that insurance said no, we'll first do robotics and things like that. And actually, Marcia did also robotics, but we didn't like it. And that's another thing. Maybe it becomes so good that but then you still don't have your own tissue, if you see what I mean. It's not your own tissue, but it's your integrated tissue for your person, which is, I think, very psychologically important factor.
Yeah.
Uh,
Yeah.
I
Thank you
don't
very
know what to
much.
say more.
Yeah.
You're welcome.
Yeah, that was a very honest and insightful conversation. Many thanks for your time and for your participation in Rise Variance about VCA. Professor Hovius, I wish you success in your work, and
Thank you.
Miss Bale, I wish you strong health and strength in your hands, and everything the best.
Thank you.
Marcia, show your hands, please.
Yeah,
Yeah, make a fist and open it and close it. Yeah. Okay. And open it again.
yeah,
Thank you.
yeah.
Yeah.
I don't
Great.
see myself, so I hope you are seeing
Yeah,
it.
yeah, yeah.
I'm seeing it very well. Thank you.
Oh,
And
Yeah.
maybe
okay,
and maybe
okay.
and maybe the scars, show the scars a little bit
Oh,
higher.
mhm,
No, higher. Yeah, good.
mhm,
Yeah, that's it. And the other one?
Oh yeah, there are bracelets.
Yeah, okay. Thank you.
mhm.
All right.
Yeah, so
Yeah,
this is well thin,
Yeah, this is the bad arm because there are
the bad arm. Yeah.
hardly any muscles there left. And so we had to take the high forearm muscles to use instead of the lower forearm muscles. Yeah. And thank you. I want to thank the whole team, by the way. I'm only one spokesman of a whole team. So I want to make a gesture also to the team and thank
yeah,
them by this way too. Yeah.
yeah,
And
yeah,
March most.
yeah.
Thank
Yeah,
you.
thank you.
Vasily, thank you.
Thank you. Yeah.
And good
Have a
luck.
nice
Good
evening.
luck.
Thank you. Thank you. Yeah.
Okay, thank
Yeah.
Maartje,
you.
blijf je nog even?
Ja.
Ja, is goed.
Ja.